We are seeing a number of BCMA-targeted treatments coming through, and we already have 2 CAR T-cell products licensed, namely cilta-cel and ide-cel, and 1 bispecific BCMA antibody teclistamab. But these are all licensed for patients who are multiply relapsed, typically in the 4th, 5th line and beyond setting in their triple class exposed. What we do know historically from other myeloma treatments is that if you move it to earlier lines of therapy, then these treatments are better. And we're already seeing early data from bispecific T-cell engagers at earlier lines of therapy, and we're seeing improved responsiveness. What's interesting is that we've recently seen CAR T data from KarMMa-3 and CARTITUDE-4 for patients 1 to 3 or 2 to 4 prior lines of therapy, and again we're seeing very good efficacy results. But I think more importantly, the safety signals are better because we are able to treat a more sensitive type of disease, and we have lower rates of CRS and ICANS. We are also seeing the same with antibody-drug conjugate belantamab mafodotin, with combination data with pomalidomide, with the ability to reduce the dosing schedule to Q8. Once you do that, you see a median progression-free survival of 21 months with pomalidomide and much lower levels of ocular toxicity. So there's some very exciting data moving all of this forward. But the challenge that then occurs is how best should we sequence this? Because we now have antibody-drug conjugate combinations, we have bispecifics and CAR T-cells. And what we're looking at is the impact of doing this. With belantamab, what's interesting is that you don't tend to get BCMA loss. The mechanisms of resistance are different. However, with more immune-based treatments, we do see BCMA loss at about 8 to 10%. But on top of that, you probably get some mutations in the binding site, and the quantification of that we still don't know, but it's going to be higher than that 8 to 10%. And then finally, with the immune-based regimens, you get T-cell exhaustion. So putting it all together, what we can't do is move from a T-cell engager into a CAR T-cell, and there's some concerns about the fitness of the T-cells moving forward with that. But we may be able to sequence antibody-drug conjugates and the immune-based therapies. However, what the data that's emerging is that you do need to leave a treatment-free interval between these 2 agents of at least 6 months.